One of my patient's cancer diagnoses came after he was walking like he was intoxicated. The tumor was in his throat, not his brain or his spinal cord. My name is Dr. Alex Watson, and I get people ready. I'm a double board certified physician in physical medicine rehabilitation and obesity medicine. I take this expertise in metabolic and rehabilitation medicine, and I help patients prepare for major medical procedures. In this series, I'm sharing my best insights for prehabilitation before cancer treatments. And I'm also giving away the cancer prehab chapter of my book for free down below. My only minor request is that you give this video a thumbs up and subscribe so you can see when the next video in the series is released. Don't worry, they are all filmed. This is not going to be one of those channels that can't finish what it gets started. This is part 4 of a full series on cancer prehabilitation. You can watch them in any order, but the first videos went through how prehab is structured, how it can benefit you, and how I adjust my plan of attack based on different types of cancer, with a full overview of cancer types. Swing back to those after now learning about different paraneoplastic syndromes, like my patient's struggles with walking, which are effectively an autoimmune condition triggered by the body fighting cancer itself. This is going to be a great one for patients and trainees alike, so stick around. I include this section to put minds at ease, or at least explain why certain things may be happening that don't seem related to cancer treatments. A good example here is that a patient back on my inpatient rehab days who had recently had a resection of a laryngeal cancer. We had a squamous cell carcinoma that had originated on the larynx. He had a history of smoking, but he developed a lot of balance issues and some other subtle signs. And this ended up being a paraneoplastic syndrome when immune system attack to fight the cancer ended up attacking parts of the cerebellum. So in this case, with these paraneoplastic syndromes, a lot of times when you treat the cancer, the syndrome goes away because there's less for the body to attack. So you can essentially treat that paraneoplastic syndrome by treating the cancer. So I'm giving you this insight to provide hope that any sort of odd paraneoplastic syndrome is not going to be a permanent thing necessarily. May require rehabilitation to get over it, but in the end, it will have opportunities for treatment like anything else does. Okay. So there are a couple different categories based on organ systems and cancer types and that kind of stuff, but go through the best we can. So the first one is a commonly taught one in med school and is on every single board exam, but it's Lambert-Eaton myasthenic syndrome, or LEMS as we often abbreviate it. Sometimes people say Eaton-Lambert instead, depending on whose name goes first. This is a relatively common condition where antibodies end up attacking part of the place where nerves meet the muscle and control muscle contraction. It's almost like myasthenia gravis, but instead of having weakness as activity goes on, LEMS, it starts out weaker. The more you use the muscle, the more you get this potentiating effect, and strength actually improves. We see this most commonly in cases of small cell lung cancer. A lot of these syndromes actually occur with small cell lung cancer. Odd things like this happen with it. It's 3% of cases of small cell lung cancer. But we also see it sometimes with lymphoma and other cancers as well. Typically, this weakness is in the legs, and there may be some other autonomic issues, blood pressure, heart rate control, that kind of stuff too. There's some cases too where that's the identifying symptom and signs, and then once you identify LEMS, then you start looking for, all right, is there a cancer associated with this that we can end up treating? And in some cases, you might catch it early enough to treat it more effectively. There are literally dozens of known neurologic type paraneoplastic syndromes. I am not going to go through all of them. I'm not going to torture you with that, but I just picked a handful to show you that in some cases, if you have a certain kind of cancer and odd neurologic symptoms, look into that. Find out if it can be related here, because it very well may be and may have its own unique treatments to it. There's another rare condition that is more common than limbic encephalitis called anti-NMDA encephalitis. NMDA receptors are receptors in the brain that is a target anesthetics like ketamine work. When you have this autoimmune attack on these NMDA receptors, this causes a brain on fire type syndrome. So I think there's a book called Brain on Fire that talked about NMDA encephalitis. It is the most common autoimmune encephalitis, with 20% of cases associated with tumors. In this case, like a lot of other ones, small cell lung cancer is one of the main cancers with which it's associated, as well as ovarian teratomas. These are ovarian tumors that can do all kinds of quirky things. Don't Google it. It gets weird. So this starts typically with psychiatric symptoms, then progresses to unconsciousness and coma. Will include some movement disorders as well. Autonomic instability again, so that's going to be your blood pressure, heart rate, things like that get difficult to control. It can also have some seizures associated with this one as well. Another one, cerebellar degeneration. One of a number of different cerebellar type paraneoplastic syndromes. The cerebellum is the part of the body that helps coordinate movements. Essentially, any sensory feedback goes up the spinal cord, coordinates through the brain, the main part of the brain here, your cerebrum, but it also sends some of that information to the cerebellum, which it then feeds back out to correct movements. So you have this constant feedback loop of movement and movement control dictated by your awareness in space, as well as your brain's perception of what it needs to do to correct changes in that place in space. So when you have attacks on the cerebellum, you have ataxic gait, what you see for someone who's had a lifetime history of drinking too much or is acutely intoxicated, just that poor coordination, essentially. All right, so I was looking to find a clip to demonstrate an ataxic gait pattern, but kept finding all kinds of weird, not appropriate ones. I figured, why not record it myself? So in this case, you're looking for variable stride length, so someone whose foot placement is not consistent, but instead it's going to be kind of all over the place because they're trying to get their balance. Their trunk control is going to be affected, and just generally looking off balance. I'll do my best here. So it's kind of short, but basically just wanted to see that there's no coordination between essentially the cerebellum, where all the feedback is being processed, and then it goes to a different part of the brain to coordinate changes in muscle tone to correct for imbalances. So when you have that attack on the cerebellum, you can't get that self-corrective mechanism, and so the person is going to be watching their feet, wide-based gait, to try and get the balance as best as possible, but still struggle with that. Hope that was helpful. Cerebellar degeneration is seen with ovarian cancers, breast cancers, small cell lung cancers, Hodgkin lymphoma, and some other ones too. This one's rare, 0.2% of cases of cancer. So besides the ataxia, because of that feedback loop between the brain, the cerebrum and the cerebellum and back and forth, and also some of the vestibular system in your inner ear, besides the ataxia, you'll have some issues with nystagmus. That's the fast beating movement of the eyes back and forth or up and down, and sometimes rotational, but don't overcomplicate things. We don't have to. As well as dysarthria, slurred speech, as that is part of kind of similar space in the brain. All right. So again, there are way more neurologic ones than I'm going to list here. So we're going to move on to endocrine, different hormonal systems that can be affected by paraneoplastic syndromes. Some of these are much more common. The first one is going to be one that we learn about a lot in med school and residency, because not only is it fairly common, but also has some pretty important implications, and when you catch it early, it's really important too. So this is the hypercalcemia malignancy. This is actually the most common paraneoplastic syndrome, affecting 10 to 30% of cancer cases. The most common causes are going to be multiple myeloma, renal cell, so kidney cancer, certain lung cancers, and breast cancer. The point of this one is that the cancer produces a hormone that's very similar to a hormone the body normally produces. Normally, you're producing parathyroid hormone by the parathyroid glands, and the cancer ends up producing PTHRP, parathyroid hormone-related peptide. So essentially what you have here is the symptoms of this are going to be symptoms of high calcium levels, because that's what is happening. Your body leaches calcium out of the bones, retains calcium from the urine, all this stuff, absorbs more from your diet. And so you get these really high calcium levels, causes GI symptoms, constipation, causes mood symptoms, bone pain, confusion, fatigue, and then even arrhythmias eventually. But if you catch it early enough, you can manage it. Also cause a lot of urination and thirst because of some of the osmotic effects and all this stuff. And then your body try to fix it, because that's how you lower calcium levels, by increasing hydration. All right, another really common one is SIADH, or the symptom of inappropriate antidiuretic hormone release. So SIADH is actually really common with a lot of situations. Excessive pain, stress, antidepressants commonly will have kind of an SIADH picture. And essentially what this is that your body just releases too much antidiuretic hormone. So what that does is it makes your kidneys reabsorb a lot of water, so you dilute your sodium levels down. And this can cause kind of similar symptoms as the hypercalcemia malignancy, but for totally different reasons, because this doesn't really affect calcium. But it can cause headaches and kind of just general feeling of malaise. Low sodium levels can give you some nausea, But if it gets really bad or really quick, abrupt drops in sodium can do all kinds of weird things. They can do all kinds of weird things because fluid moves where it shouldn't, and it can affect the myelination of your nerves and cause all kinds of bizarre stuff because of that. So another one to catch early, another one to treat when you can. Unfortunately, treatment for this one, I'm going to warn you ahead of time, is often fluid restrictions. Even though they're diluting your sodium down, we don't always give salt tabs. Often part of the treatment is bad enough. But usually what you end up doing is just restricting fluid intake because your kidneys are hanging on to enough water that you don't need more fluid, but you're still kind of thirsty. Not the most comfortable treatment. And then finally, Cushing's syndrome. That's the last one we're going to cover for endocrinology. It's another relatively common, better known one, even for non-medical nerds like me. This is when your body produces too much cortisol. So there's Cushing's syndrome and Cushing disease. Cushing syndrome is any situation of having too high cortisol levels. Cushing disease is when your body has a tumor that produces cortisol. So this is common in small cell lung cancers, thymic tumors again, bronchial carcinoid tumors, a certain neuroendocrine kind of tumor in the lungs, and then also pancreatic neuroendocrine tumors. Not exactly the adenocarcinoma that is the pancreatic cancer most people know of. There are other kinds as well that can do more on the hormonal side of things. For small cell lung cancer alone, this is 1 to 5% of those cases can have Cushing's syndrome associated with it. The symptoms are going to be anything that you associate with high levels of steroid hormones. So striae, which look like purple stretch marks, weight gain, kind of a rounded face, weight gain right at the back of the neck here, as well as muscle wasting, just general weakness, really high blood sugars. So being able to catch this and treat this is really important as well. That's super weird. It just got really dark in here all of a sudden. Okay. After a little dinner break, in all seriousness, let's get back to some of these paraneoplastic syndromes. Moving on to hematologic ones. These are blood-related paraneoplastic syndromes, things that can happen when the immune system starts going off target and messing with parts of the blood that you don't want it to mess with. So the first one is common in pancreatic cancer and is so much so that it's kind of a buzzword for our typical standard exams here in our medical training. This is what we call migratory thrombophlebitis, also known as Trousseau syndrome. Both of those aren't really very memorable for most people. But what this really is just recurrent, spontaneous blood clots in veins. So we see this in pancreatic cancer. It's kind of well known for that, but actually it occurs in other kinds of cancer as well, such as gastric cancers, lung cancer, and colorectal cancer as well. As far as incidence, this is going to happen in about 10 to 15% of cases of pancreatic cancer, and then a little lower, somewhere around 5 to 15% of certain other kinds of adenocarcinomas, like lung cancers and whatnot. So dermatologic syndromes. The first one, I almost don't want to say this, but it's an important point to make, but I don't want everyone who has this for benign causes or relatively benign causes to think that they have cancer. But acanthosis nigricans is a darkening of the skin in the armpits, kind of the back of the neck. Sometimes you see this with insulin resistance, way more commonly than with cancer, but we do see this in cases of cancer, the paraneoplastic syndrome as well. Commonly see this in GI cancers, so gastric cancer, also in lung cancers, and then as well in breast cancer. Basically, 2% of cases are malignancy related, so that means 98% are your typical kind of metabolic type causes. Okay, another kind of buzzwordy type thing is dermatomyositis. This is a certain kind of rash that when we see this, we jump towards, all right, let's look to make sure that there's no cancer hiding somewhere and causing these problems. We're taught the association with cancer so frequently. For someone early in training, they may jump to think of this as, you see dermatomyositis, you're going to find cancer, but in actuality, the minority of cases are related to cancer. In total, about 15 to 30% of these cases are cancer related. We see these in cases of ovarian cancer, breast cancer, lung cancer, and colorectal cancer. Now, if you think about the name means dermatomyositis, the myositis part is muscle inflammation. So it presents with weakness, usually kind of proximal muscles, so thighs and shoulders, and then a couple other very specific kind of rash symptoms. So Gottron's papule, or just raised rash on the knuckles. You also see this heliotrope rash, which is kind of purplish rash around the eyes. All right, we're moving along here to rheumatologic paraneoplastic syndromes. The first one is called hypertrophic osteoarthropathy, which just means hypertrophic, excessive growth, osteoarthropathy, bone joint dysfunctionopathy. So in this case, that's going to present with overgrowth of certain joints, like clubbing of the fingers, Clubbing is when you get this bulbous appearance of the end of the fingers. You can Google that. It's really common to associate with a lot of other things too. So again, don't see this and immediately think you have some rare paraneoplastic syndrome necessarily. The incidence is about 1 to 10% of cases of lung cancer. We also see this in mesothelioma, which is not technically lung cancer, it's cancer around the lungs, the mesothelial lining, associated with exposure to asbestos and certain other irritants to that lining, as well as thymic tumors. On top of that, besides the clubbing, you also get kind of periosteal bone deposition. So you get bony type calcium deposits and whatnot near long bones. So that's like your femur. Then you also get synovitis. So that is inflammation of the synovium. That's the kind of part of the capsule in joints. You get this arthritis type pain in the wrists and ankles. Similar feeling here. There's also paraneoplastic polyarthritis. So that's literally just arthritis of many joints. This is pretty rare, but you see it in lung cancer, breast cancer, colon cancer, and lymphomas. This looks a lot like RA. So rheumatoid arthritis has inflammation in the wrists and the hands and the knees, kind of like really any joint technically. There's some characteristic findings here, but it's seronegative. So it doesn't have the normal blood markers of rheumatoid arthritis, and then also doesn't respond quite as well to the same disease-modifying anti-rheumatic drugs, DMARDs as we call them, the medications we use for rheumatoid arthritis. All right, so the next type of paraneoplastic syndrome, we're going to have a category of metabolic. And some of these might not be as obviously metabolic. The first one is tumor lysis syndrome. That's what happens when the tumor starts breaking open, lysing, and all the gunk starts getting out of the system. You get a characteristic elevation in certain metabolic byproducts of tissue that's breaking down. So it's going to be hyperuricemia. Uric acid is a part of gout. This can actually cause gout, and I've seen it. Poor gentleman with renal cell carcinoma as an intern who came into the emergency room, was admitted because he had gout tophi, growths in the skin and joints all over his body, extremely painful because gout is painful when it's in one joint, let alone your entire body. But also causes elevation of other electrolytes like potassium, so hyperkalemia, phosphate, hyperphosphatemia, decreased calcium, though, so hypocalcemia. The problem is the electrolytes end up causing all kinds of secondary issues. So worsening kidney issues, which then further worsen electrolyte problems. The electrolytes also make you really prone to feeling terrible. So, nausea and all that stuff. But really the biggest problem is the cardiac arrhythmias that happen because of that. This can be fatal. Finally, non-islet cell hypoglycemia. So it means hypoglycemia, low blood sugar, not from the normal pancreatic places. So the islet cells are what normally produce insulin in the pancreas. So if you have hypoglycemia from non-islet cell sources, that means it's not the pancreas releasing insulin, so it's something else. This can come from liver cancer, can do this one, as well as adrenal gland, adrenocortical carcinomas. This manifests as recurrent hypoglycemia, really severe. All of a sudden, blood sugar is tanking. This kind of goes along with something like similar to insulinoma. Untreated, it can cause loss of consciousness and coma and really severe things like that too. So this is pretty broad, but we want to cover some unique treatments that may not have a full weight of deep research, but instead to get your mind kind of active and thinking about unexpected effects of cancer that might respond to treatment. Kind of identifying things, taking away some of the fear and uncertainty, and then also providing a little bit of hope that there are treatments for these unexpected symptoms. All right. Thank you sincerely for hanging with me through all those details. Again, please like and subscribe so others can find this resource during their cancer journey. If not already, the next video should be up within a week, and that one will be covering the exact exercises that I prescribe cancer-fighting gladiators.